While we're waiting for a few others to join, maybe what we should do is just go around. I know a few of you, but not all of you. I'm Ken Sag. I'm in rheumatology, and I direct the Center of Outcomes Effectiveness Research and Education. And why don't we just start here, and then we'll see who's on the line with us. Just your name and your general affiliation.
Ben Kasten. I'm a postdoctoral researcher in the Department of Neurosurgery.
Thank you.
My name is Ilaria Betello. I'm a postdoc fellow in Dr. Beer lab in the Cancer Center.
Great.
My name is Yulia, and I am a graduate student in Dr. Eric Roberson's lab in neurology.
I'm Claudette Poole, and I'm a fellow of pediatric infectious disease.
Terrific. Thank you.
My name is Ashley Nember. I'm a resident in radiation oncology.
I'm William Kilgo. I'm a fellow in neuroimmunology, Department of Neurology.
Great, and we have a few people on the phone with us. Can you hear us okay on the phone?
Yeah, we can hear you. This is Nathan Penner. I'm a PharmD with Auburn School of Pharmacy.
Thank you for joining. Anyone else on the phone with us today?
Hey, this is Josh Hollingsworth. I'm an assistant professor of pharmacology at Edward Via College of Osteopathic Medicine in Auburn.
Welcome.
This is Jamie Roper. I'm an assistant professor in the School of Kinesiology at Auburn University.
Anyone else? Thank you. Great. Does anybody else not introduce themselves? Good morning.
Good morning. I'm Colleen Yanushevitz. I'm a first-year pre-doc in the School of Nursing.
Great, great. Well, we have people at different locations and clearly with very different backgrounds. And I think for some of you, this is a little bit of a departure in terms of topics and maybe something newer to some of you that are particularly more laboratory-based. We're going to talk about health services research and comparative effectiveness research. I was looking back, given this talk to different groups over many years, and the title changes a little bit. Sometimes I call it health services research, other times it's comparative effectiveness and patient-centered outcomes research, and I'll explain how those things are more synonymous than they are different as we go along. But the byline to the title is actually of some relevance, since we're talking not about bench to bedside research, the traditional type of translational research, but we're talking about later stage translational research. How do we take evidence, particularly, and translate that evidence into practice? So what I'm going to do is spend a few minutes just on some terminology and talk a little bit about how this sort of came to pass and what has happened at a national level that's kind of driven some interest in this area, specifically some funding mechanisms that we're always all interested in, where can we apply to get grant money? And that often, although we like to be focused in our research, we also have to be somewhat opportunistic, and we have to take advantage of opportunities for funding with different agencies. And then I'm going to give some examples, and the examples will come from my area of interest and research in arthritis and osteoporosis. But I'll try to, provide some clinical context. The point is that these are just examples, and the methodology and the approaches are generalizable to other areas. So I don't think if you're in neurology or other areas that these approaches could easily be incorporated. And here are some of the examples that I'll cover. So I think it's good just to sort of put, again, this into broader perspective. And you can see in this diagram developed by the Institute of Medicine, now the National Academy of Medicine, the different types of research and where they fit across a spectrum from bench research all the way over to applied health policy and bioethics. And what we're going to talk about today really is in this area here. Now, can people see when I use the mouse on the webinar? Are you able to see my arrow? Can you see that?
Yes.
Moving the arrow around? Okay, good. So I'll use that to point if I do point, but sometimes that does or doesn't show up, so I just wanted to know. But So health services, comparative effectiveness research, draws on principles from epidemiology and biostatistics to try to generate knowledge that can be used to help deliver improved quality of care, and ultimately we hope would influence healthcare policy, and also ties into the area of disparities research quite significantly. And then this is another way to think about this, and kind of a cascade of different acronyms, but you can see health services HSR over here to the side. You can see comparative effectiveness research, which is a slightly older term. This gained a lot of popularity a number of years ago with stimulus funding, when there was a big bubble of money that was a couple $2 billion was out there to spend, and funded some grants that we got here at UAB, both training grants and science grants. And then newer term is patient-centered outcomes research, or PCOR. PCOR came to pass when the Patient-Centered Outcomes Research Institute was developed, and I'll explain that in a second. And what a lot of us have been interested in is the area of pharmacoepidemiology. So a lot of the questions that we have are about the safety and comparative effectiveness of drugs, devices, and biologics. And how do we test those, and particularly how do we test those in a real-world setting using large databases? So that's really what pharmacoepidemiology is. And so these things overlap more than they don't. And as I suggested, a lot of this excitement, interest, sort of newfound enthusiasm, if you will, was generated by this entity, which was created with the Affordable Health Care Act, the Patient-Centered Outcomes Research Institute. It's kind of an odd entity. It's not NIH. It's not under HHS. It's actually a pseudo-government entity that was legislated. And then, in essence, it's a tax on insurance. When you buy private insurance or public insurance in the U.S., there's some money from that that goes into a trust fund that is used to fund this. Now, the most important point to make about this group, this agency, or this funding organization, if you will, is that we don't know what's going to happen to it. Again, it came under the Affordable Health Care Act. It's not clear that it's going to be reauthorized, and some of the activities that have been occurring within it are moving into some different places, and they're sort of spinning off their own identity. And let me tell you a little bit about that. But first, just so you can get a sense of the scope of this, you can see the portfolio and the amount of money that is available for supporting research grants is not at all inconsequential. $500 million of dollars available for competition. UAB has been the recipient of a number of awards here, and interestingly, whenever a sister agency, the Agency for Healthcare Research and Quality, shown as the asterisk at the bottom, receives money for training, the money comes from PCOR. So PCOR money is going to AHRQ to fund our T32 here, which just got renewed, and a K-12 that we've had that is also in patient-centered outcomes research. And here's just a few of the different entities or different RFAs that have come out, I should say. You can see the different topics around assessment of prevention, diagnosis, and treatment, improving healthcare systems, communication, disparities, accelerating methodological research. More recently, there's actually been a big pool of funds that were identified for supporting pragmatic clinical trials. I'll describe that and give some examples in just a second. And one of the things that PCOR has done that I think has been really quite innovative is they've created something called PCORnet. And this is a network of research centers throughout the country that are linked through a coordinating center. They include clinical data research networks and patient-powered research networks. UAB actually is the lead on one of these PPRNs, patient-powered research networks. And the idea is to take data that's being collected. In this case, it was from an online support group for people with arthritis and to actually bring that data in and connect that data in other ways, make it research-grade data, and use that data to answer important questions that are important to patients. So what are the things that patients want to know about, and how can that information be gleaned from that source of support? Now, what's curious is that this entity is now spun off into a private entity. So it's no longer sitting under PCORI, but it's actually its own private entity, and they're actually now issuing RFAs and raising money from the private sector to continue its support well beyond the period of investment from PCORI in it. So that is promising. I think this is really exactly the thing nationally that we need to be doing. We need to figure out how to combine our data across centers and to be able to use minimal data sets with things like I2B2 here at UAB and other approaches. They have a different structure of the data than I2B2, but it's the same idea, using the electronic health data, combining that with administrative claims data, which I'll talk more about, and thinking about how can that information be harnessed to answer biomedical research questions. Just to give you a sense of what things have been funded by this group, I think it sort of shows a fairly common number of diseases. We've got neurologists here with us today. You can see mental disorders and nervous system disorders rank highly. Cancer, not surprisingly, CVD, all the usual things, kind of in some ways representative of the prevalence of conditions. They've also been very interested in rare diseases and making sure that rare diseases don't get shortchanged in their support. And then these are the different approaches that have been used for doing the research. Mixed methods, RCTs, observational studies, secondary data analysis, and others are listed there. Here's one example, a study of comparative effectiveness or rehabilitation services for survivors of stroke. You can see how this was an interesting approach, which used stroke registry data linked to Medicare data. So you can take a registry and then link it to claims data from Medicare, and some of the strengths are listed here. It's a nice example of a great project that really benefited from this source of support. So these are some of the domains. Now, where did this list come from? We wrote a training grant a few years back in response to a request for applications from the Agency for Healthcare Research and Quality. And these were the different dimensions of comparative effectiveness research, patient-centered outcomes research, health services research that they listed as important topics to consider. So longitudinal studies, real-world studies, evidence implementation, pharmacoeconomics, methodological innovations, and systematic reviews and meta-analyses. I'm not going to have time to talk about all these, but I'm going to use this as sort of the framework for reviewing some of this with you. And before doing that, I want to just keep this fairly general and think about, again, the paradigm for where we are between evidence implementation and evidence generation. Most of the time, most of us think about studies that are generating evidence. We do observational studies. Sometimes we do interventional studies. We may, for some in the room, to be in the preclinical area, we may be doing discovery, things that are at the bench that may have some early phase translational potential. Once we've done these types of studies, sometimes the information that is gleaned is not sufficiently robust, and we may want to try to combine smaller studies in a formalized way. That would be a meta-analysis to try to make sense of underpowered studies answering maybe a difficult question. If we've done this, and if we have good studies, we might be able to aggregate that information in the form of guidelines. So we might use systematic approaches to developing guidelines, and then those guidelines might be used to define the quality of care. And we can define quality of care not by a guideline, but by a standard measure, a performance indicator. A guideline is the best you should do. A performance indicator is what's the minimum you should do under a given circumstance. If a certain circumstance exists, what should you do as a minimal standard of care? And we can then measure performance across doctors, health plans, patients, whatever entity denominator you want to use to see how is healthcare being delivered. And not surprisingly, we see a lot of practice pattern variation, which often represents some differences in dissemination, disparities in care delivery. And then ultimately, a lot of the research that fits into this rubric is the idea of TRIP, translating research into practice. How do you take the evidence and how do you get the evidence out there when we know that many times there may be clear evidence, but yet people, doctors, patients, health systems aren't getting that evidence into practice. We'll talk about some approaches to that as well. So let's start off with the top bullet and look at what we mean by longitudinal cohorts of effectiveness and safety, and particularly focusing on therapeutics and other interventions. And just, I'm going to review some principles of epidemiology because I think it's important to think about the methods that we use to answer these questions and what are the strengths and limitations of these methods. That has relevance for the quality of the studies, but you can see a paradigm for the different types of things we can do, from very descriptive work to more analytic work. This work can be prospective, retrospective, cross-sectional. When we do prospective studies, we can observe people prospectively in a true cohort design, or we might intervene. We can intervene in the form of a clinical trial. We can randomize people to receive or not receive a particular intervention and then balance the baseline covariates that might be important to know about. We can also do retrospective cohort studies or case control studies, which have some additional forms of bias that are introduced. So this is back from Intro to Epi from the Henneken's book that reminds us just about sort of the reference frame. When you're doing a prospective cohort, you are collecting information on exposures, and then you're following people forward in time. A great example would be the famous Women's Health Initiative, started many, many years ago, collecting data about risk factors, following people forward to cardiovascular and cancer outcomes. You can also do a retrospective cohort where both the exposures and the diseases have already occurred, and you look backwards and you follow people from when they had a particular exposure to the development of a disease. Or you could flip this around and you could look at the outcomes and look backwards to see what the exposures were. That's actually a case control study. And I'll give some examples of this as we move along. And many in the room are no doubt familiar with the idea of risk estimates, or relative risk from a cohort study, and odds ratio from a case control study. This is an approximation of the relative risk. And then of greater public health significance is the absolute risk, the risk difference. Let me give an example, again, from the Women's Health Initiative, a very famous cohort study which has looked at estrogen and progestin and what effects they may have on various health outcomes, such as fractures, heart disease, cancers, etc. And you can see that in some cases, for hip fracture, for example, taking estrogen combined with progestin actually was protective. It lowered your risk of a hip fracture, and you can see that there was a reduced risk per 10,000. This is the risk difference. Now, if you look, however, at heart disease and breast cancer, we see that there's up to a 30-fold increased risk and an excess in terms of these adverse outcomes. You also notice here that when the relative risk does not include 1, we say that that is a significant risk estimate. So you get a sense both of the magnitude, the significance, and then the population-based risk difference, which gives us information about the relative risks and benefits of such treatments. Now, when we look at data from observational studies in particular, there's different possibilities when we see a result and we see an association. And we want to use the word association because in many cases, these are not causally related things at all. You might have a true association, in which case things could be causal, but you could also have a chance finding. And the chance finding is protected by the p-value, the alpha, if you will, the alpha error, the type 1 statistical error. So that's how we address that. What about confounding and bias? What do we mean by these constructs? And those are also possibilities when we see an association. Bias is a systematic error in your study design. And the only way you can handle bias is in the design of the study. You can't explain bias away analytically. Confounding, on the other hand, is when we see a false positive association between an exposure and the outcome of interest due to a relationship of the exposure and outcome with a third independent factor. So a great example of this is the appearance that if you drink more, you're more likely to have lung cancer. Now that is confounded because people that drink more are more likely to be smokers. So smoking is confounding the association between alcohol and a cancer outcome. And there's different ways that we can address confounding. The best way, probably, for if you can do it, is you can do a randomized design where people are assigned by chance to receive or not receive a particular intervention. So you can do a clinical trial. And if your study is large enough, you ought to have an equal balance of the factors that might be explaining baseline differences between the two groups that you're testing. If the study's smaller, that may not be the case. You could restrict, you could limit the characteristics, you could do matching. These are all in the design phase. Or when it comes time to analyze the data, you could do different analytic approaches. You could look at different strata, subgroups. You could do simple adjustments. And we see very commonly in many of our reports multivariable adjustment or the use of sensitivity analyses, best case and worst case scenarios. Those are ways to try to understand the possibility of confounding.
Dr. Say, can you go back once to the slide and give an example of restriction, please?
So restriction would be, let's say we're worried in a study that there's going to be a major confounding effect of age. And we think that the treatment is going to be affect people significantly different if they're over 80. So we could restrict the population in the clinical study to less than 80. So the problem is when you restrict, then you limit your generalizability. So you've eliminated the ability to answer the question in those older people. But if you're worried that they're going to behave differentially, that there's going to be confounding or effect modification by that other variable, you could restrict the population. And we do that all the time in clinical trials, in the inclusion criteria. If you're developing a drug, you often, and we'll get into this in more detail, in the initial proof of principle of that drug, you want to know whether the drug works. And if you have a lot of noise in your signal, it's going to be very problematic. And so that's where restriction comes in. But then the limitation is you don't know about its effects in important subgroups. And that's why many drugs get approved, they come out onto the market, and then we learn things about them later on that we didn't see in the clinical trials because we really didn't test the drug in that particular subgroup due to restriction. So thank you for that question. And please jump in as we go. That's very helpful to get clarifying questions as we go along. So a risk factor is what we think about in observational studies that provide a signal, but it doesn't suggest causality. It's like looking for the key under the lamppost. It's where it's easiest to look, and it may generate hypotheses and help us ultimately understand mechanisms. Now, this is a really important slide, and if you haven't seen this before, and if you do any kind of observational research, you should always be thinking about this. And if you read any good paper in observational study, and in the discussion section and the limitations of the discussion, you'll see people address this indirectly, if not directly. This is the Bradford Hill criteria for causality. And when we do observational studies, we often are not able to establish causality. But if people start to fit into these categories, if the results show a strength of association, if they show dose response, if there's consistency with prior observation, if there's clear temporality where the exposure predated the outcome, and of relevance to all of our scientists in the room who work in the lab, there has to be biologic plausibility. Does this make sense? Is there some mechanistic understanding? That's necessary but not sufficient, because we've got lots of examples where things look biologically plausible, but then when we actually test it in a clinical setting it doesn't work or there's a side effect because of something that we really didn't understand. And wouldn't it be great also if there could be reversibility? So that's a very difficult one. Example from my field is in gout, when we know that urate level, as the urate goes up, which is the cause of gout, that people have worse disease and may have more risk of other outcomes like hypertension and cardiovascular disease. Well, if you give a medicine that lowers the urate, you can actually reverse that. And would that then help make some of those things go away? Could you see reversal of hypertension or cardiovascular disease or other things? So that would be an example, but there's not, unfortunately, a lot of examples in science of where we can actually use that. So let me show you some examples and look at some strengths and limitations of study design, longitudinal study design. So this is a retrospective cohort study of a question around a commonly used medicine, prednisone and steroids, and the effects of that medicine on different serious outcomes, adverse effects. You can see the list, and for all the clinicians in the room, this is a very familiar list of things that can occur if you take glucocorticoids, prednisone, for a long period of time. And so we did a retrospective cohort of patients with rheumatoid arthritis. We identified steroid users. We found non-users who were matched by age, sex, and duration of disease. And we looked descriptively at these various outcomes. And you can see that fractures were at the top of the list and seemed to be more common in those who were users of glucocorticoids. So what's the problem here in looking at the data this way? So one of the problems is that the people who get steroids don't receive them randomly. So there are people who are, they're clinicians, they're doctors, and other clinical care providers are more concerned. And they've decided that they need this medicine. And they may be people who may be prone to develop these same outcomes independent of getting the steroids. So that's a problem in all observational studies of drugs and therapeutics called confounding by indication. We don't randomly assign people in clinical practice to receive or not receive therapies. They get them for particular reasons. So one way we can address this is, again, this idea of dose response. And here you see Kaplan-Meier survival curves. Here's the group that didn't get prednisone. And here's the probability of being free of a bad outcome, one of those adverse events. So these people were all free of it. These people all had it. This group here that didn't take prednisone at 5 years still had a 20% chance of having one of those bad outcomes just because of them being sicker and older and having rheumatoid arthritis. However, if they took between 10 and 15 milligrams of prednisone at 5 years, they had a nearly 80% chance of having a bad outcome. So it suggests a dose response, which speaks to those criteria of causality, the Bradford-Hill criteria, dose response. Now, we also attempted analytically to adjust for confounding by indication. And what we did here is we included measures of more severe rheumatoid arthritis, as indicated by these two variables, and you can see they were significantly associated with the bad outcome. But even after analytically accounting for these bad outcomes in a multivariable logistic regression equation, we still saw a dose effect of steroids, prednisone, on the bad outcome. You can see that this was highly significant, particularly at the higher dose. So it suggests an association, but it's very difficult to take away all the confounding because we don't know what all the factors are, and sometimes we don't have data that adequately address that. So the limitations of our observational studies of drugs is this idea of confounding by indication, also known as selection bias. Sicker patients are treated more aggressively. Another bias that we deal with is the bias of detection. If we're doing observational studies and we're not following people in a standardized way, it may be that you're more likely to be found to have a fracture if you show up more. If you're on steroids, maybe you're seen more frequently and you're more likely to have that entity entered into your record and it shows up more. So can we use randomized controlled trials to fix these biases in observational studies and address these questions? And randomized controlled trials have a higher place in the evidence pyramid. We can see this pyramid with systematic reviews and randomized trials, and then we move down to physiologic studies and unsystematic clinical observations. This is a very common pyramid of evidence that we always think about, and we always want to try to go as high in the pyramid, and there's some variability when you look at these. This one is from the Cochrane group, Gordon Guyette. Some people would have a really well-done randomized trial at the top. This N-of-1 study is an unusual study design that we don't do very much. And meta-analyses, while very helpful, systematic reviews also have problems. There can be difficulties in publication bias and problems with errors made in meta-analyses. Yes?
Could you explain a little bit more what you mean by N-of-1?
Mm-hmm. So an N-of-1 study is when you have a particular person who you're seeing in a clinical setting, and you basically challenge them and de-challenge them with a particular therapeutic, and you do it in a systematic way. And so if the effects are, and there's some permutations on this, there has to be good washout of the drug or whatever it might be, but you can actually see precisely whether that therapy is having a beneficial or deleterious effect in that individual person. And there's formalized ways to do it, but we often do it informally in clinical practice. And so that is in essence what often this idea of challenge and de-challenge, re-challenge would be with a particular drug in clinical practice.
So would that, well, similar to that Dr. said, would that be like a food challenge in the allergy clinical practice?
It could be. It could be any kind of exposure. It could be a food. It could be a drug. Probably not. It could be a device. I mean, it just would depend on what the question is that you're interested in addressing. Now, clinical trials generally are a gold standard, but I want to come back to the steroid question and the issues around fractures and other bad outcomes of steroids. It's a topic I've been interested in. And when we look at studies in the literature, most studies that have randomized people to get or not get steroids in rheumatoid arthritis have been down in the range of just a few hundred individuals. And what you can see is that you need to have a very high rate of an outcome and a very significant difference, an odds ratio of 2. If you design a clinical trial or you design a study, you generally want to power it to have a much lower minimal detectable odds ratio. Typically, you want to be able to pick up a 50% difference. And for that to occur, you're going to need a much greater sample size. So the practical implication of this is that it's, in some cases, impractical to do the clinical trial you need to do in certain circumstances. So we're stuck relying on observational data if we neither have the resources nor ability to recruit people for such studies. So what can we do? Can we use other sources of information to help us answer some of these questions? And one source are these databases of large insurers, which this lay publication tells us we should be looking at. So observational studies can be based on claims data. These are the data that are collected for billing purposes. We have administrative codes that are entered. Now it's ICD-10, not ICD-9. And then all this data can be culled. It can be purchased. In the case of Medicare and Medicaid data, we can buy it from the government, and we have groups on campus that have expertise in using it. You can get it from private sector entities. You can collaborate in different ways. You can get access to this data. Here's some of the resources at UAB, and this is a little bit dated, but it changes over time. But we have Medicare data, Medicaid data. We've worked with Aetna data for those who are affiliated with the VA. It's a very tremendous resource which has both administrative data as well as very comprehensive electronic health record data. So this is all billing data, but this data can be substantially enriched by the presence of data from electronic health records, if that data can be culled and used in a systematic way. Let me give an example of how we might use this data to answer observational questions. So I'm going to come back to another drug group used in arthritis, in this case in rheumatoid arthritis, called the anti-TNFs. These are drugs that block tumor necrosis factor. And these were first developed now almost 20 years ago, and were shown to be very efficacious and really were game changers in treating people with severe inflammatory diseases like rheumatoid arthritis. However, when these drugs came out, there were questions about their safety. There were concerns about infections, both common and atypical, other issues, but there were some uncertainties. Was it the drugs themselves, or was it this issue of confounding by indication? The people who were treated with these drugs initially were ones that were sicker. Now, in some of the clinical trials, we saw signals as well. So there, if you randomize, and the studies are big, you would think you would have explained that away. Or could it have been co-therapy with other medicines that were confounding things? In any event, this led the FDA to issue a variety of black box warnings and concerns about these drugs for very rare side effects. And this was an example of one of the warnings that the FDA put out for kids, for children who take these drugs occasionally with a rare form of arthritis, juvenile chronic arthritis. And so one of my colleagues in pediatrics, Tim Buchelman, who's a pharmacoepidemiologist, was interested in studying this question, and he was going to study this within the Medicaid healthcare system. So Medicaid is, I think most are familiar with it, it's a healthcare system for people that are underinsured and often have lower financial means, and this would be a group potentially at higher risk for bad outcomes. So while there may be some limitations in the generalizability of the population, if anything, you might expect this to have higher rates of bad outcomes. And he was interested in comparing the rate of malignancy among children with juvenile inflammatory arthritis compared to children without this condition. And so here's what he found. He looked at the standardized incidence ratio, and for all the children with arthritis, they had a rate of infection, which is listed here, and this was compared to non-juvenile inflammatory arthritis children with attention deficit disorder. So you wanted to get a group of kids who were seen commonly, who had another chronic condition, but didn't have obvious reasons to get infected. So that's regrettable to see that just having the arthritis itself predisposed to developing the bad outcome. And then he looked at other medicines. He looked at other commonly used drugs, methotrexate in this case, and showed that that also had an increased risk. But when you look just at these drugs by themselves, he actually didn't find any cases of serious outcomes like malignancy, and a subsequent paper looked at chronic infections. So it appeared, at least using this large Medicaid database, that this was not something of major worry. Now, I think we want to be careful in interpreting the results again of observational data, recognizing that there may still be underpowered studies, but it is a very interesting way at a large population level to look at this. And you can do other things. These are other publications that have come out of UAB in high visibility journals like JAMA, looking at infections and herpes zoster, shingles. Just a few examples, just to show that collaborations can be constructed across academic groups using these large administrative data sets, in some cases combining data from Medicare with other private sector databases, and answering questions of some scientific significance that lead to high impact publications. So this data allows us to utilize large national data sets that have fewer selection biases. It has pretty good generalizability because it's such a big data source and it's population-based. And it can complement other approaches. It can complement registries, and it can be done at a relatively reasonable cost. But like all data sources, it has limitations. So what are some of the problems with administrative data? The first is that it's relying on coding. It's relying on billing data. So there's misclassification and miscoding. That's a big problem. It also, in the case of arthritis, we don't have any information about disease activity and severity, so that's a big limitation. And we can't easily differentiate incident from prevalent outcomes. We can have left and right censoring. People may come in and out of different insurance plans. If you're looking at Medicare, you don't have information on people before they are of Medicare age, so you don't really know if they had arthritis 10 years earlier. You don't know whether that's a new case or an old case in that circumstance. And we may not have detailed information on some of the comorbidities. So back to the circumstance of observational studies. or randomized controlled trials. And some people would say that if you find a study was not randomized, we'd suggest you stop reading that paper and move on to the next article. And then Feinstein's a little more sanguine. We need both types of studies to answer different questions. Here's John Ioannidis, who's a little bit of a heretic, but he shows that in large RCTs, randomized controlled trials, likelihood of truth is 85%, meta-analyses 40%. In large, well-done epidemiologic studies, only 20% likelihood of getting the right answer. The classic example has been the Women's Health Initiative, where we thought for many, many years, based on observational data, that estrogen was actually protective for developing heart disease. And it wasn't until the Women's Health Initiative was done that there was evidence that it might increase the risk. So that was an example that's fueled some of this debate. But when the data actually was reanalyzed from those observational studies using a more sophisticated way to address confounding by indication, in this case using marginal structural models, they got similar results. So the methodology is very important. In well-designed observational studies, others suggest don't systematically overestimate the magnitude of effect, and there's been little evidence that observational studies were consistently larger or qualitatively different from RCT. So I think my conclusions are that it's not fair to compare good randomized trials with bad observational studies, and we need to do observational studies better. We need better methodologies, more standardized approaches, recognizing that not all questions lend themselves to clinical trials. So let's talk for a minute then about real-world clinical trials. What do I mean by that? Well, these are the different phases of drug development. The clinical folks in the room are familiar with this. Phase 1, healthy volunteers. Phase 2, dose escalation. Phase 3 is the pivotal clinical trials used for regulatory approval. And then most of what we're talking about today is Phase 4, after therapies come out, trying to understand post-marketing issues, comparative effectiveness research, pharmacovigilance, pharmacoeconomics. Why do we need better trials? Well, most trials have compared interventions to placebo, and that doesn't answer the relevant questions of how to choose one drug over another. Not all questions can be answered and need to be answered by traditional clinical trials, and traditional clinical trials are expensive and inefficient. If people have done those, they know this. I mean, it's very difficult to recruit. We talked about selection earlier. These are some of the limitations. So a newer form of studies have gained some traction, and that's the idea of a pragmatic clinical trial. So a traditional clinical trial has very high internal validity and very low generalizability. A pragmatic clinical trial flips it around, and we measure real-world effectiveness. Another synonym is large, simple trials. Minimal inclusion criteria, low risk, simple treatments, and objective natural endpoints. Let me illustrate this. So efficacy versus effectiveness is what we're talking about here. Efficacy is what happens in a tightly designed phase 3 clinical trial, selection of a very specific population, prone to healthy person bias, the absence of subgroups, tightly controlled follow-up, strict protocols, and we make sure that people are adherent to therapy. Maybe there's a placebo run-in, a period of time when you aren't even on study drug, but we see whether you're going to take your pills just with the sugar pill first and then follow people for a period of time after that. If they do well, then they get to get the actual study drug and get randomized. So an explanatory trial figures out, typical clinical trial, whether the treatment possesses the favorable activity and manner which laboratory studies led us to suspect. Can it work under ideal circumstances? These are efficacy trials. Pragmatic trials assess the practical value of a new treatment in relation to other existing treatments. Does it work under usual circumstances? Effectiveness trials, management trials, large, simple trials. But it's not a dichotomy, it's a continuum. And if you look at an example of compliance in a traditional clinical trial, we might exclude people who are non-compliant using a placebo run-in. We might apply a compliance improving strategy to everybody. Or we might monitor compliance in a slightly less efficacious study in a more pragmatic trial, and we might intervene if people are doing poorly. We could monitor only, or in the most pragmatic of study designs, we could completely ignore adherence and see what happens in the real world. So it's answering a different question. It's answering the question of what happens in actual clinical practice. So now if you write a grant to PCORI and you're trying to get funding to do a pragmatic trial, you need to fill out this spider diagram. And this was developed by Thorpe, and it shows the different dimensions of things that might define explanatory in the middle, the things that are most pragmatic on the outskirts of this. So how do you use this? Here would be a study, in this case, looking at self-administered versus observed tuberculosis therapy that was considered highly pragmatic, and this would be a study that was considered highly explanatory across these different dimensions. So let me give an example. AllHat. This was a study that looked at lipid-lowering treatment to prevent heart attacks and antihypertensive drugs, and it compared low-cost diuretics to new, more costly blood pressure drugs. 8-year study funded by the Heart and Lung and Blood Institute. UAB was a big recruiter for this. Over 40,000 people, large certainly, and it cost $125 million. So that's a big problem. We aren't seeing studies funded by anybody, really, other than maybe large pharma, that come in at this price tag. And so this is a real rate limiter. So we put together a group of stakeholders, patients, physicians, researchers, policymakers. We looked at the different stages of the study process, and we thought about how could we do pragmatic trials better. Maybe we could have more practices that weren't experienced in research to create further generalizability. We could use practice-based research networks. We could improve and make more efficient the informed consent process. And wouldn't it be great if instead of relying on people coming into a clinic to get an evaluation, if we could link people with their claims data? We could link the study participants to Medicare data in the case of a study looking at a fracture outcome where those fractures are captured very nicely in claims. So we got some funding from NIH. We had a planning grant and a pilot grant. And we designed a study to address a question about how long should people stay on their osteoporosis medicines. There were some and there still are some very important questions about the duration of use of a group of drugs called bisphosphonates, alendronate, risedronate, zoledronic acid, brand names Fosamax, Actonil. You may have heard about these drugs, and while these drugs are highly efficacious at reducing fractures over a short period of time, they're curious drugs because they build up in bone, they stay in bone, so they may have protracted efficacy even after you stop them, and they've been associated with very rare outcomes when used long-term, atypical femoral fractures and osteonecrosis of the jaw. So our first innovation in this was to figure out where could we get 20,000 people, which we calculated as our sample size. And so we started looking at the different large healthcare systems that were affiliated with the Health Maintenance Organization Research Network. And we found that even within one of the large Kaisers alone, there were 25,000 users of one of these medicines, alendronate. So that looked like a rich resource. And we did the usual things when you do clinical trials. You've got to figure out how you're going to recruit and what materials you're going to develop. So that's important. And you have to be able to explain the study in a simple way and describe it, come up with a catchy acronym and a logo and a website. We developed a customized iPad application. They say this guy looks like me, but and so, you know, the avatar comes out and talks about the study design, and you can see here the two women, one's going to stay on her medicine, the other's going to come off, and this is after they've taken this drug for 3 years. They can actually be quizzed on the consent form while they're doing it to see if they understand what in the world they're getting into, and then they can do e-signature, which is nice. They can do that. The consent form can be mailed to them electronically, so you can see some of the efficiencies of this. If you're doing this in onesie-twosie practices in Wetumpka, these doctors could participate. We could make it efficient for them to enroll patients in such a study. That was the idea. And so we did all that work. We did all the planning. We developed a manual of operations. We developed the protocol, and we came back to the NIH and we said, we did what you asked us to do. It's going to cost $20 million to study. Is that okay? And they said, no, that's not okay. We don't have that much money. So it turns out that regrettably we didn't get the big study funded. And it may be that they were right, because the question is become very difficult to answer. Many people have already adopted a practice without the evidence of stopping people from these drugs. And so the ability to find long-term users of these medicines has diminished greatly since we first envisioned the question. So they may have made a good decision. And we learned a lot methodologically and have used our technologies to fund other studies, including a study looking at zoster vaccine and arthritis and other things that are underway here at UAB. So you always learn something even when things don't work out perfectly. One of the goals of all of this is to think about the idea of a learning healthcare system. How do we build research into practice? How do we make it so that when you come to see your doctor, it's really a research-grade encounter, and the data being collected could inform research? And there's some ethical imperatives that are listed here that suggest that this may be, to society, a major benefit. So let me talk for a few minutes then about one final topic, and then we'll break a little early today. But I want to speak about evidence implementation, risk communication, and dissemination. I'm not going to cover these last three areas. I'm just going to finish up with this. And here's another paradigm slide from some of our former UAB colleagues. Amanda Salinitro is now at Vandy, and Carlos Estrada is still here, but Jerome Allison is up at UMass Worcester. We call that UAB North. All a bunch of our faculty. We're getting a little bit of background. If you could perhaps mute your phone if you're not talking, just to avoid some of the background. Thanks so much. And here you can see how we sort of conceptualize this final phase of translational research, implementation research, late stage translation. And this is really one of the central tenets of health services research from Donna Beaton many years ago. You have somebody who's in an initial health state and you're trying to transition them to a better health state. And you can do this in different ways. You can affect the process and the structure of care, and ultimately that will have an impact on the outcome. So these are the two things that we can impact. And as we look at this, we'll see different approaches that target structure and process. What do I mean by process? Well, process would be if you're trying to improve, you're trying to lower fractures in osteoporosis, you might get people to have more tests, or you might have people to receive more treatments. And through clinical trials, through sort of the transitive property of epidemiology, we think that if we improve the rate of testing or treatment, and there's clinical trial data to suggest that doing so leads to a better clinical outcome, namely fewer fractures, then we've actually done something valuable. So if A equals B and B equals C, then A ought to equal C, right? So we ought to be able to have an intervention that increases a process, a test or a treatment, indirectly affect the outcome. Wouldn't it be great if we could measure the outcome directly? That would be better, but often we're underpowered and we don't have enough time, or we don't have a way to track that outcome in a clinical study, testing an approach to treatment. So outcomes research has some tenets. Outcomes, not geography or ethnicity, should determine the treatments a patient receives. Variation in practice are often indicators of disparities in care and differences in outcomes. We also want to incorporate patient values and preferences into our decision making. So we're not surprisingly doing a tremendous job of delivering high quality care. Looking at performance measures back in the early 2000s, it was shown that adults were getting about half of the recommended quality measures. This is a paper that has been quoted a lot. And this is just an example of the translation gap. You can look back to the use of beta blockers. They were first tested in the late 1950s. They were then shown to work in 1964. Some of the clinical trials start to get done. And it took about 20 years from the time of developing these to the time when everybody pretty much after a heart attack was getting a beta blocker. That seems like a long time. And it suggests that we've got an underuse gap. It's a good story in some ways because the groups that measure quality have actually retired the quality indicator for getting a beta blocker after a heart attack. It's got a ceiling effect, and now 90+% of people get it, so it's not worth measuring anymore. But unfortunately, it took 20 years to get there. So when we think about quality improvement, which is a subset of evidence implementation, there's different kinds of errors that we can make and we want to try to avoid. Underuse, the example that I just provided. Overuse, antibiotics for a common cold, a big problem. And misuse, this is often the problem in the hospital with hospital-acquired infections, falls, other things that occur. How do we prevent adverse outcomes and misuse of resources? One of the things that we're seeing more and more is the increasing focus on overuse, and many groups have come up with their top 5 list. What are the 5 things in a particular area of medicine that are deemed to be of low value? So cardiologists have done this. This has been done in the arthritis field. Many groups have developed their top 5 list. It's not just about cost. Cost is important. Something can be very expensive, but if it has high value, it might not make the list. But if it's expensive and it has very limited impact, then that would be the kind of things that we'd like to get rid of. And then this is not at all uncommon anymore, and this is the idea of report cards that can be directed at healthcare providers or health systems, and be assured that when our hospital administrators see University of Alabama Hospital here, and the state average is here, this catches their attention. And they want to know how to fix this. And so what can we do at a system level to improve healthcare quality? So we first have to measure it, we have to identify a problem, and then we need to think about what we can do to improve it. It's sometimes not easy to define quality. Here are some examples of what healthcare quality might be. Health services for individuals and populations that increase the likelihood of desired outcomes are consistent with current professional knowledge, and these are the dimensions: efficacy, equity, efficiency, safety, timeliness, and patient-centeredness. So implementation research is the study of the rapid uptake of findings in an effort to improve the health of individuals and populations. It's at the intersection between quality improvement and epidemiology. It uses methods from health services research and qualitative methods. It's translation science that goes beyond the bedside. How can we implement evidence? Well, we can give our patients and our doctors materials. They get smarter, but they don't change their behavior. We can do continuing education for the healthcare providers in the room. You go and hear a lecture. Often you get smarter, but you don't change your behavior. We can do intensive conferencing. This works around things like smoking cessation, time and cost intensive. You could use computerized tools, reminders that pop up on the electronic health records. Most clinicians have figured out how to get away from those and extinguish all of those. Or you could do outreach or a special type of outreach with local opinion leaders, academic detailing. This has been shown to work, again, very costly. I showed an example of auditing feedback with the report card. And what we thought over many years is that multifaceted and multimodal approaches were the best strategy to improve quality, and that these would be the sorts of interventions that would work. So oftentimes when we design these programs, and when we do rigorous tests of these programs, they don't work. And it's not because that people are not smart or that they don't get it, it's that there's a misalignment of incentives and it may not be delivered at the right time. So these are the targets of activities aimed at improving quality. They can be healthcare providers, patients, or the health system. So I'm going to give some examples. Here's an example in diabetes. This was a report card developed for clinicians. This was done using something called the Achievable benchmark of care. This was a quality metric that was Bayesian adjusted for the practice size. You can see up at the top the average, your practice, and then down below it the state average, and then the benchmark. And you could see how you were doing compared to others across some measures of diabetes quality, from cholesterol to whether people got vaccinated, did they have their feet examined, etc. And it turned out that this Achievable benchmark actually performed better than a previous metric that had been used by CMS. So that was encouraging. And so we were very interested in this approach, and we knew about a problem back to the steroid issue. Many of our patients that were receiving these medicines weren't being tested or treated to prevent the fractures that we saw in the very early study that I showed you. You can see that for men it was particularly poor. Things got a little bit better between 2 time periods, but we saw very low rates of treatment in men and younger women, and even among women generally beyond the age of menopause, where the risk is greater, the rates were still relatively low. So we designed a cluster randomized trial within the Aetna healthcare system. We figured out who were using steroids. We found out who the doctors were that were prescribing these medicines. We randomized these doctors to a control arm or to an intervention arm. The intervention included an internet-based intervention that I'll describe. We looked at baseline rates of testing and treatment, and then we measured follow-up rates after the clinical trial. Here's the intervention. It used the Achievable benchmarks of care so people could see how they were doing compared to their colleagues. There was case-based interactive learning. We had a toolbox where they could get materials, they could get online continuing medical education. We rolled it out over 6 months to combat any decay, and this was the result of the clinical trial. And the intent to treat analysis, which is the way to analyze clinical trials, there was no significant effect of our intervention on improving quality. When we looked at the docs who did what we wanted them to do, this is a per protocol analysis, those that went online, those that downloaded their material, did the cases, we started to see some trends perhaps towards some improvement. And it suggested to us that in this particular circumstance, where we weren't really in a teachable moment, if you will, that targeting the physician and provider might not be the right approach, and we may need to think about other strategies. So newer work we've been doing and work by others, started by one of our former colleagues here, Tom Houston, has used narrative communication, the idea of storytelling, narrative testimonials about what it's like, homophily. People relate to things that sound and remind them of people they know. The power of narrative to change belief has never been doubted and has always been feared. So brainwashing, if you will, but hopefully for a beneficial purpose. Here's an example of where this might work. This was a study done at our county hospital, the Cooper Green Hospital, a safety net hospital, done by Jerome Allison and Tom Houston. They developed a grainy DVD, a home movie style DVD of mostly older African-American men who'd had complications of hypertension, strokes, and they sat people down in the waiting room, mostly again African-American men, sat them down in the waiting room and showed them these DVDs. And they randomized them either to get or not get the DVD. And those that got it actually had a significant improvement in their blood pressure, particularly among those that had worse blood pressure. And that led to a paper in the Annals of Internal Medicine. So a poignant example of a very low-tech approach, low-tech generalizable approach to improving quality tested in a rigorous way using narrative communication. So here was an example. I actually forgot to upload the video clip. Let me see. Well, that's all right. This guy tells a story about what it's like to have fractures. He doesn't look like a fellow that you'd expect to have fractures. And that was a study that we've completed now, looking at a way to improve quality with steroid use. Here's another low-tech approach. This is a system-based intervention where we're allowing people to get their own bone density test without a prescription. And you can see the usual rate of receipt of bone density testing. These people were randomized to usual care. And then when they were randomized for self-referral within 2 of the large Kaiser systems, Kaiser Northwest and Kaiser of Georgia, they could just call a 1-800 number. We saw a significant improvement in the rate of receipt of this test. And these were women who were eligible to have one but didn't appear to have one from their medical record review. So I want to sort of summarize a little bit, and then we have a few minutes, I'm sure, for questions and discussion. So evidence implementation research, first we have to define quality. We have different things we can do. This involves multidisciplinary teams. We need behavioral scientists, we need epidemiologists, we need people that understand the clinical questions, and it's not easy to do this. Technology offers promises, theory-based creativity is key. one size fits none, and approaches need to be tested, because when you do traditional quality improvement, it often looks like things get better, but sometimes it has nothing at all to do with what you did. It may just be temporal. It may relate to other things. And this is an example of that, showing how in uncontrolled studies things look great, 80% positive results, but look what happens when you actually have a control group. It's a flip result. And that was evidenced in the study that I just demonstrated to you, where we actually did this in a rigorous way. So let me conclude with just a few general suggestions, some places you can look for funding. We've talked about PCORI. NIH has a growing interest in many of these areas across the agencies. HRQ is another HHS agency. We've had training grants from them. We had, for 17 years, the Centers for Education and Research on Therapeutics, which was a large federally funded center. That program ended, but they still are funding some R01s. The VA, the merit program through HSR&D, has been very beneficial to UAB in helping us grow this portfolio. And some of our studies are funded by the private sector. Resources include people here within the CCTS. We have an outcome center that you're welcome to reach out to me at any time, and I'm happy to make matches and to connect you with people that I think would be appropriate if you are engaging in this area. Different professional societies focus on this. Academy Health is the large health services research organization, the International Society of Pharmaco Epidemiology, Society of Medical Decision Making, and Society of General Internal Medicine are all groups that have had a very rich interest in health services and outcomes research. And then we have different training opportunities and offerings. We have our T32. We have different postgraduate or graduate, rather, programs of study and certificates that are available. All this is here, and I'm glad to talk with you individually. So our future is bright. We have lots of infrastructure at UAB. We have our peer group, which has large databases. We have had our search, which now, with the program ending, is no longer. More recently, we have an Institute for Cancer Outcomes and Survivorship, led by Smita Bhatia, and we also have a new activity led by Mike Mugavero, located over in FOT, called SCORE, which is doing some great work in this area too. So let me conclude there. We went just a little over an hour, and I know we have some more time this morning, but that's what I wanted to share with you, just kind of an overview of the area of outcomes research and health services research, a smattering of some different topics and approaches. Hopefully, this sort of puts it into a framework that makes it a little bit more understandable if you haven't thought about some of this before. And for those who have thought about it and are in this area, gives you some examples of some things that are happening here at UAB. So I'm happy to break and answer some additional questions. Thank you. Questions?
I have a question. So, Dr. Stagg, you showed us that in arthritis patients, if they received higher dose of prednisone, they were at higher risk of having fractures and other adverse outcomes. Can you tell us if those research findings have led to any kind of setting guidelines in using prednisone in those group, or actually change of practice among rheumatologists in treating arthritis? Because I assume that they use heavy prednisone because of more severe arthritis.
Yeah, it's a great question, and it's actually a somewhat complicated answer because, first of all, there's been tremendous practice pattern variation in the use of prednisone in different forms of inflammatory diseases, particularly rheumatoid arthritis. In the U.S., the use has diminished over time, but it's remained relatively stable now for some years, partly because these drugs work so effectively and make people feel so much better that there's still a baseline rate. Part of that decline has been the development of new steroid-sparing drugs, like some of the ones that I mentioned that have their own set of safety issues. Quite curiously, in Europe, in certain parts of Europe, there's been an increase in steroid use, and that has to do with some of the limitations that I highlighted in the observational studies, and the fact that it's a whole separate lecture that I give, but we can really get into the details of where the observational studies have flaws, and frankly, where the clinical trials have flaws. But the clinical trials have not shown a significant increased risk, and we know that steroids in rheumatoid arthritis actually modify the disease and that actually reduce the progression of rheumatoid arthritis to develop bone changes and erosions in the bones. So that's led some people, particularly in countries where there's more financial constraint on the use of some of the newer, more expensive drugs. I mean, these anti-TNF drugs are ridiculously expensive. You see them advertised on network TV, right? You turn on the 10 o'clock news and they're running ads for these anti-TNF drugs. Think about that. Those are drugs that soaking wet may be used by maybe 5% of the population, maybe. It's probably closer to 2 or 3%. Okay, that's the total prevalence of all the diseases for which they're used, and they're able to advertise on network TV. So that tells you a little bit about the profit margin with those drugs. So they're dramatically effective, but they're also dramatically expensive, and they do have their own toxicity. So interesting societal issues too. Other questions? Anybody on the phone have any questions? All right, well, we'll break a little early. Thanks again.